Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we focus on person-centered care for treatment-experienced people with HIV. How can you address each person's specific medical history? How can you account for their personal priorities? And how do you factor in comorbidities and other health challenges? To answer these questions, I'm joined by Dr. Clíona Ní Cheallaigh from Trinity College, Dublin. To hear a larger discussion or to follow along with the slides, visit the show notes for this episode. Now let's get started.
So there's a lot to think about when you have a patient who is treatment experienced sitting in front of you in clinic. And we're going to try and tease these things out one by one. But some of the things that you're going to need to consider are practicalities around whatever you're proposing for the patient to take now, such as insurance and co-pays, food requirements, storage requirements, interactions with other medications the patient may be on, and how your proposed regimen may affect the patient's other comorbidities or co-infections. Also important to think about their HIV disease and their HIV treatment history and whether or not they have any acquired HIV or transmitted HIV resistance. Also really important, if the patient has previously failed on treatment, to think about why this happened and is there anything you can do now that might reduce the chance of this happening again. And absolutely central to this whole process is the patient themselves and the psychosocial aspects of their care, because these are really important in making sure that this regimen is a success. So we're going to start with a case of Brendan. And Brendan is a gentleman who was diagnosed with HIV in 2006, and his engagement in care has been erratic over the years. Comes into clinic, takes his medication, then he vanishes for a number of months or years and then comes back again. And he was initially treated with Adherence containing regimen, and when he failed on that due to intermittent adherence, he developed resistance to both NNORTIs with a K103N mutation and to 3TC with an M184V. He also found boosted PIs very difficult to tolerate, as many patients do, with a lot of GI symptoms of nausea, vomiting, very frequent diarrhea that was really limiting his ability to engage in other aspects of his care. The COVID pandemic made things even more difficult for Brendan, and he was lost to follow-up for a period of 5 years. And he's now represented to clinic, sitting there in front of me, and I'm trying to think, what am I going to do now for this gentleman? He lives alone in a rural area where he's quite isolated and he's not working at the moment. And he's got very extensive internalized stigma, a lot of shame about having HIV. He's a man who has sex with men. This is how he acquired it. And in his community, this would have in the past not been socially acceptable. And so he's really worried about people finding out about this. He also has a lot of long-standing depression and anxiety, and would have a lot of anxiety about mixing in social situations. So all of this has made it difficult for him to engage in care. He's a smoker and he does have a family history of cardiovascular disease. And on clinical examination, we can see some oral candida. So that would already indicate to me that his CD4 count is probably on the lower side of things. When his bloods come back, his CD4 count is 120 cells and his HIV RNA is 400,000 copies per mil. So the first thing that I do when I see a patient like Brendan in clinic is really focus in on the patient-provider relationship, because that's going to lay the foundation for any future therapeutic endeavors and interventions. And especially for somebody like Brendan, who's maybe carrying a lot of shame, has had negative experiences around his HIV and his HIV acquisition in the past, it's really important to make him feel that he can be safe, that he can tell us what's going on, and that he's going to be treated in a non-judgmental and supportive way. There is really important. Something that I found beneficial in my clinical practice is emphasizing continuity of care. So people who've had very difficult lives may find it difficult to repeat the same story to every provider. And so if they have continuity of provider, that may help them stay engaged. So with that as the foundation, we're also trying to think about the other things that may help him adhere to the regimen this time. So we know he didn't adhere to a regimen in the past. So is there anything that we could do in terms of maybe helping him get funding for transport to clinic? Maybe that was one of the reasons he disengaged in the past. Maybe he needs some education on HIV and its current management and what to expect. Something simple like medication reminders or a Dosette box can help. And you want to reduce the complexity of the regimen and address side effects wherever possible. So as I've said, with the patient-provider relationship being the foundation of anything that you're going to do. One approach that I found works really well in my practice, where I work with a lot of people who've experienced social exclusion and usually have had very difficult childhoods and difficult adult lives, is to use the principles of trauma-informed care. It's really important to consider power dynamics and cultural issues and things like where you're sitting in relationship to the patient, how you speak to them, your body language, and considering cultural issues. So I would always tell patients that I'm not going to give out to them, be cross with them, and to really kind of try and address their fears about being judged and shamed in an open way so that they know that I understand that they may be feeling ashamed, but that I'm definitely not going to shame them. And there's lots of information on this online that you can look at that will be useful. But basically what you're trying to do is make the patient feel safe and in control as much as possible in order to give them the best chance of engaging with their care. As I said, you want to think about why did they fail their treatment before, and is there anything you can do to modify any of those variables? And if they've been on previous non-suppressive ART, you need to think about have they acquired drug resistance during that period, and that you're going to need to assess that and know what that is to factor that into your treatment choices. Obviously, you're going to think about interactions with other drugs and pharmacokinetics, and then you need to think about the urgency of restarting ART. So obviously in Brendan's case, his CD4 count is quite low. We don't want him, going around with that for a long time. But we do also need to think about, are there any more pressing needs for Brendan, maybe housing, maybe addressing his mental health that need to be addressed either in parallel or first. So say in Brendan's case, we know he's got psychiatric disease, he's got depression and anxiety. Is that optimized? Is he linked in with medication and counselling support for that? If he's got an addiction, is he linked in with that? And really trying to address all of those other elements that are important in making sure that he is able to adhere. Another thing that I found useful in my practice is exploring the why for ART. And if you're working with people who live in communities that have experienced a lot of social adversity and potentially a lot of premature mortality, so say, for example, in people who inject drugs, there's a lot of premature death in those patient populations. Longevity, living healthily and well into their 80s or 90s, may not be a goal for that patient. And so you need to explore why might they take their ART. Maybe it'll give them more energy. Maybe it'll make them look more healthy so that people won't be saying to them, oh, you don't look well. Their mood may improve. So really tease out with the patient what's important to them and how the ART might support that. You need to explore why not. And sometimes the why not can be concerns regarding horror stories that they've heard about other people who are on regimens that maybe we haven't used for the past 10 or 15 years. And it's important to explore those fears. Sometimes there could be concerns around inadvertent disclosure. If a patient is living in a congregate setting where they have other people sharing their room that they haven't chosen, that they don't want to disclose to, they may be concerned that having a pill box with a HIV medication's name on it may result in inadvertent disclosure. And you need to really address all the practicalities around how is the patient going to get the medication and store it and take it, so that all of that is thought through. Then you need to decide whether you're going to restart ART today in clinic or whether you're going to do that later. And there's a number of reasons why you might decide to do one or the other, and whether you're going to restart with the same regimen or whether you need to change ART regimen and start with something else. And one of the things that you need to think about is, based on their prior regimen, are they likely to have developed resistance to it, in which case you're not going to restart it? Or were there any side effects or other aspects like dosing schedule or the size of the pill that were contributors to them not taking their ART? This is a really common pitfall about resistance testing. So yes, you do want resistance testing because you want to know whether that your patient's virus has mutations that are going to result in certain agents not working. But if you send a resistance profile on the day that you see them in clinic, that's going to be wild type virus. It doesn't have the selection pressure of ART. And so what you ideally want to do is do resistance testing either before they stop taking their prior regimen or within 4 weeks of discontinuation. Or if they have stopped, as in Brendan's case, and represented, you want to do your resistance testing about 4 weeks after you've restarted, so that wild type virus will be suppressed and any potentially resistant virus will be detectable. And you can do genotypic or phenotypic testing. Phenotypic testing is reserved for when you're expecting very complex drug-resistant mutation patterns in patients who've got extensive prior treatment exposure, and so wouldn't really be indicated in this setting. We're just going to go for genotypic testing. And so, as I said, you're going to wait 4 weeks before you send them. Right, now what are you going to choose to give this patient? So because of how HIV virus replicates, the number of errors per replication, it can quickly evolve a resistance if there's pressure from just one active agent. So you never want to add just a single active agent to a failing regimen. You can do 2 fully active new agents if one of them has a high resistance barrier, like dolutegravir or a boost darunavir. And or sometimes if you're really in a difficult situation, you might consider adding 1 fully active agent with 2 agents that you think, 2 NRTIs that you think may be partially active. But it is preferable where you can and where you have the luxury of choice to add in 3 fully active agents. So there have been questions as to whether it's worth using NRTIs in the setting of where there is partial resistance, where you have resistant mutations to them. And if you are combining them with agents with a high barrier to resistance, like dolutegravir or darunavir or ritonavir, it does seem that even in the setting of NRTI resistance mutations, they do contribute to full virologic suppression. So even though they may only be partially active, they're still going to contribute a benefit and they're worth adding in. We're sort of, when I see a patient in clinic and I'm restarting them on ART, I'm running through the different options in my head. I think most clinicians do that. And so, individually kind of thinking, will this one work? Will that one work? So we know they got very bad GI side effects in the past with boosted PIs, and these are likely to occur with other boosted PIs. And when you have adherence issues, if you can avoid a drug that's going to give somebody unpleasant side effects, you're going to do that. So we're not going to give him a regimen including a boosted PI. We also can't use Adherence because we know he's a K1L3N. And first line in our practice would be to use 2 NRTIs and an integrase inhibitor like dolutegravir, which we know has a high barrier to resistance. And this is an acceptable regimen for Brendan. We know he's never had an integrase inhibitor before, so he's not going to have resistance to that. And he had no integrase inhibitor resistance at his baseline testing or on previous testing. So he didn't have transmitted virus that already had integrase inhibitor resistance. We could, if he didn't have an M184V, we could consider treating him with 3TC and an integrase inhibitor. But in his case, we know he has an M184V, so we're not going to do that. The 3TC by itself with the dolutegravir is not going to be strong enough to keep him suppressed. But we could potentially think about long-acting antiretrovirals with cabotegravir and rilpivirine, possibly, ideally after he's been suppressed or in certain other settings, such as enrollment in a clinical trial. But Brendan doesn't seem to have many issues with taking an oral medication once daily, so we're going to go ahead and restart him on 2 NRTIs and an integrase inhibitor. So I'd like to talk a little bit about ACTG A5359 or latitude. And this is a really important trial for the patient population that I work with, where very frequently the people living with HIV that I work with have had issues with adherence and really daily oral medication in the setting of perhaps homelessness and active drug addiction, or in the setting of very extensive internalized stigma and difficulty taking your tablets every day because it's a reminder of your HIV, are real barriers to care. And it was very exciting initially when cabotegravir or rilpivirine was released. It was for people who were engaged in care and who were virally suppressed at the time of initiation. So it really wasn't at that point recommended for this patient population. But there's evidence emerging that actually, as part of a interdisciplinary package where you're really trying to address all the barriers to adherence, that it does seem to be a promising alternative. And so I'm really looking forward to more evidence emerging on this, but I think it's very promising for people who have really, really, really high levels of difficulty engaging in care, as well as those for whom engaging in care is easy. And the failure of the regimen is less in patients who are on long-acting antiretrovirals. So I think this is really promising, and I'm looking forward to seeing a lot more work in this area. In fact, the results were so positive that the study was stopped early because there was superior efficacy of long-acting cabotegravir and rilpivirine in secondary outcomes, virologic failure, treatment-related failure, and permanent treatment discontinuation. So I think this is a really promising addition to the HIV physician's toolkit. So Brendan, as discussed, he's actually happy to take tablets once a day. Would counsel him that usually most patients don't experience a huge amount of adverse effects or GI side effects on this. And then if he re-engages successfully and becomes virally suppressed, we can consider about switching him to a long-acting regimen if that is something that he chooses and that we think will be feasible for him.
Thank you, Dr. Ní Cheallaigh, and many thanks to you, our listeners, for joining us. To listen to other episodes in this series on HIV care for treatment-experienced people, click on the link in the show notes. And to get access to all our new podcasts, subscribe to the CCO Infectious Disease Podcast wherever you get your podcast. Thank you, and we'll see you on the next podcast soon.